Hello and welcome. I am Dr. Anoop Lal, and over the next half an hour, we are going to discuss the management of hypertension in the community. This video is created based on the guidelines prepared by the American Society of Hypertension and International Society of Hypertension, published in the year 2013. These guidelines are all about flexibility in the sense that the authors have taken into account the great variability in access to medical care among communities across the world. They have only mentioned classes of drugs to be used in specific situations, leaving to the practitioners the choice of individual drugs. Hypertension is the commonest cardiovascular morbidity, affecting around one-third of the adult population worldwide. It is the commonest chronic condition that a basic doctor will get to manage in the community. One very important aspect regarding the epidemiology of hypertension is the rule of halves, which says that even though one-third of the people in the community are affected by hypertension, roughly half of them ever get diagnosed. And among the ones who get diagnosed, only roughly half of them receive any kind of care, and among them roughly only half of them achieve treatment targets, and even among those who achieve treatment targets, only roughly half of them achieve the outcome that is desired. There is a close relationship between blood pressure levels and the risk of cardiovascular events, strokes and kidney diseases. It is estimated that for every rise of 20 millimeters mercury of systolic BP and 10 millimeters rise of diastolic BP, the risk of cardiovascular mortality doubles, which means that a person who is having a blood pressure of 175 upon 105 has 8 times the risk of cardiovascular mortality in comparison to a person who is having 115 upon 75 millimeters of mercury blood pressure. How do we define hypertension? Hypertension is defined as systolic blood pressure 140 millimeters of mercury or above, or diastolic blood pressure 90 millimeters of mercury or above. Of this, systolic blood pressure is of particular importance because it is more associated with cardiovascular morbidity and mortality. The goal of treatment is to bring the blood pressure to below these levels. But among the elderly, that is 80 years and above age group, the target blood pressure is 150 upon 90 millimeters of mercury. In addition to the definition of hypertension, blood pressure is also classified into several categories. We have a category called pre-hypertension included, in which the systolic blood pressure is 120 to 139 millimeters of mercury, or the diastolic blood pressure is from 80 to 89 millimeters of mercury. Above which, going into the definition of hypertension, first comes stage 1 hypertension, wherein the systolic blood pressure is from 140 to 159 millimeters of mercury, or the diastolic blood pressure is from 90 to 99 millimeters of mercury. Above this, we have stage 2 hypertension, wherein the systolic blood pressure is equal to or greater than 160 millimeters of mercury, or the diastolic blood pressure is equal to or greater than 100 millimeters of mercury. So this is how hypertension is classified, and the management differs on the basis of whether the patient is in stage 1 or stage 2 hypertension. We also have 2 types of hypertension. The first type, which is the commonest, is the primary or the so-called essential hypertension, into which 95% of adult population with high blood pressure fall. This is called primary or essential hypertension because the cause is not yet recognized, and they say that it could be environmental factors like excessive intake of salt, obesity, and perhaps sedentary lifestyle, and some genetically related factors could include inappropriately high activity of the renin, angiotensin, aldosterone system and the sympathetic nervous system. The second type of hypertension is secondary hypertension, which is, as the word says, secondary to some other cause, most commonly renal cause or hormonal cause. The main types of secondary hypertension are chronic kidney diseases, renal artery stenosis, excessive aldosterone secretion, pheochromocytoma, and sleep apnea. Diagnosing hypertension can be done using a conventional sphygmomanometer and stethoscope. The first Korokov sound denotes the systolic blood pressure, and the fifth Korokov sound denotes the diastolic blood pressure. Nowadays, we also have the automated electronic devices which are far better than the sphygmomanometer stethoscope devices because they produce far more reproducible results, and also the inter-observer and intra-observer variations are much less with the automated electronic devices. It's also important to know the different types of blood pressure cuffs. We have the conventional arm cuffs. Also, we have the newer wrist cuffs and also the finger cuffs. But among these, the arm cuffs are the most accurate ones, and it is always best to use the arm cuffs for the diagnosis of hypertension. And it is also important to note the size of the arm cuffs because based on the age of the patient, and also even among adult patients, based on the size of the arm of the patient, the size of the cuff will have to be changed and the appropriate cuff has to be used. Making an accurate measurement of blood pressure is of paramount importance when hypertension is being diagnosed for the first time. There are a few steps and a few guidelines that need to be followed when you are measuring blood pressure. BP should be measured in both arms when you are doing it for the first time. And the arm with the higher reading should be used for any future measurement of blood pressure. Patients should have emptied their bladders before the measurement of blood pressure, and they should be seated with their back supported for at least 5 minutes before you take the measurement of blood pressure. Their legs should be uncrossed and resting on the ground, and arms should be at the same level as the heart. Here the first and the third pictures show the wrong way of positioning the patient for measuring blood pressure, whereas the middle picture shows that the patient is seated erect with the back supported and the feet are on the floor firmly, and also the arm is supported by the table. Here you can see that the cuff, the arm to which the cuff is tied, is at the level of the heart. It is preferable to take two readings 1 to 2 minutes apart and take the average of the two. Ideally, confirm diagnosis after a second visit 1 to 4 weeks apart. But having said that, it is not mandatory because in our setting, sometimes this would be the only time that you get to see the patient. Also, watch for white coat hypertension, which is, the blood pressure will be high only when the patient is in front of the doctor, and on other instances, the blood pressure will be normal. This, if you suspect, then the way to arrive at a conclusion is by doing home blood pressure monitoring or ambulatory blood pressure monitoring. Evaluating the patient is the most important part in the management of blood pressure because often high blood pressure is only one of the several cardiovascular risk factors that require attention. There might be other risk factors as well which need to be identified and treated. Evaluating the patient includes taking detailed history, physical examination, and doing relevant investigations. In the history, we need to find out whether the patient was previously diagnosed with high blood pressure and whether the patient had taken any drugs for this, because your further evaluation and prescription of drugs will correlate with the kind of drugs he has been taking. You also need to look into other cardiovascular risk factors including lipid abnormalities, glucose intolerance or diabetes, a family history of early cardiovascular events, obesity, and cigarette smoking. History of previous cardiovascular events are also important. These factors influence the choice of drugs in the treatment of hypertension. These important previous events include stroke, transient ischemic attacks, dementia, coronary artery disease, heart failure or left ventricular dysfunction, chronic kidney disease, peripheral artery disease, diabetes, sleep apnea. Other risk factors like age, dyslipidemia, cigarette smoking, microalbuminuria, gout, or family history of hypertension need to be looked into. Another very important aspect in the history taking is whether the patient is consuming any other drugs for any other conditions. For example, non-steroidal anti-inflammatory drugs, tricyclic and other types of antidepressants, older high-dose oral contraceptives, migraine medications, and cold remedies have adverse effects on hypertension control in the sense that these are all drugs that elevate blood pressure. So when you are treating hypertension in such patients, the control of blood pressure may not be very forthcoming. You also need to find out if the patient is consuming any herbal medications, folk medicines, or even recreational drugs like cocaine. Physical examination would include weight and height and body mass index, and this helps in setting the targets for weight loss. Waist circumference is important because metabolic syndrome is a cluster of conditions which includes hypertension, glucose intolerance, and central obesity. In order to make a diagnosis of metabolic syndrome, the waist circumference should be 1 or 2 centimeters or above in men, or 88 centimeters or above in women. You also need to look for signs of heart failure. These include elevated jugular venous pulsations, basal crepitations in the lungs, and pleural edema. Neurological examinations will reveal neurological deficits that might have been caused previously. Eyes and fundus has to be examined because fundus examination will reveal signs of hypertensive retinopathy. Examining the peripheral pulses are also important in the sense that diminished peripheral pulses mean that atherosclerosis is happening and it could be affecting the heart or the brain. Investigations also help to identify coexisting morbidities as well as complications of hypertension. Blood examinations are ideally done by taking a fasting sample. The very important blood investigation is serum electrolytes. High potassium levels can suggest renal disease, particularly if creatinine is also elevated. Low values of potassium can suggest aldosterone excess. Fasting glucose concentration is again useful in the diagnosis of impaired glucose tolerance as well as diabetes mellitus. It is also helpful if glycated hemoglobin can be estimated if the patient is already having diabetes mellitus. Serum creatinine and blood urea nitrogen will help in identifying chronic kidney diseases. Lipid profile is elevated lipids are again comorbidities and risk factors of cardiovascular diseases. Liver function tests are important in the sense that they help in giving baseline values before starting medications, because some of the drugs in the treatment of hypertension can adversely affect liver function. Hemoglobin and hematocrit values are also important because in conditions like chronic kidney diseases, hemoglobin levels will be reduced and anemia will be present. Electrocardiography is again important because it can help identify previous myocardial infarctions or left atrial and ventricular hypertrophy or even arrhythmias. Urine albumin and cells can be examined, especially the urine albumin creatinine ratio will be helpful in diagnosing chronic kidney diseases. Goals of treatment, as I mentioned earlier, the target is to reduce the blood pressure to less than 140 millimeters of mercury as far as systolic pressure is concerned, and to less than 90 millimeters of mercury as far as diastolic blood pressure is concerned. If the patient is above 80 years of age, there is a slight relaxation in the systolic blood pressure target and it is 150 millimeters of mercury. The diastolic blood pressure target is the same, that is 90 millimeters of mercury. You also need to manage other risk factors such as lipid disorders, diabetes, obesity, and smoking. We also need to inform the patient that the treatment of hypertension is a lifelong process and compliance and adherence to treatment is of paramount importance to prevent the adverse outcomes of hypertension. Treatment of hypertension includes non-pharmacological as well as pharmacological management, in which non-pharmacological treatment is usually complementary to drug therapy. Non-pharmacological treatment alone can be attempted in stage 1 uncomplicated hypertension, which is not associated with any other risk factors. Even modest weight loss can be very helpful. Diet has to be regulated. Fresh fruits and vegetables can be included in the diet. Saturated fatty acids can be reduced. Salt reduction is of paramount importance. Aerobic exercise can be done regularly, at least for 20 minutes every day. Alcohol consumption and cigarette smoking has to be completely avoided. Drug therapy can be initiated when lifestyle treatments are not effective or when other risk factors are also present in stage 1 hypertension, or immediately in stage 2 hypertension, where the blood pressure at the beginning itself is above 160 upon 100 millimeters of mercury. Most patients will require more than one drug to begin with. Increase the dose of drugs or add new drugs at approximately 2 to 3 weeks interval initial dose of drugs chosen should be at least half of the maximum dose so that only one dose adjustment is required thereafter. And in approximately 6 to 8 weeks, the patient should have achieved the target blood pressure. Start with 2 drugs with BPs at least 20 upon 10 millimeters of mercury above the target level. Choice of drugs in hypertension is based upon several factors including age, ethnicity and clinical characteristics. Other conditions like diabetes, coronary artery heart disease and pregnancy. In general, long-acting drugs are preferred over shorter-acting ones because it gives much more convenience to the patients in terms of taking only maybe once daily. For the same reason, single tablet combinations are preferred over multiple tablets. The choice of drug will be further influenced by their availability and affordability. These are the 8 classes of antihypertensive agents. Among this, the most widely and most commonly used category is the ACE inhibitors and the ARBs. These can be considered as the first line drugs for the treatment of hypertension. Other categories include thiazides and thiazide-like diuretics, calcium channel blockers and beta blockers. Thiazides, calcium channel blockers and beta blockers are sometimes regarded as the second line drugs in hypertension control, whereas alpha blockers, centrally acting agents, direct vasodilators and mineralocorticoid receptor antagonists are usually considered as third line or fourth line drugs. Coming to ACE inhibitors, they prevent the conversion of angiotensin 1 to angiotensin 2 and also they increase the bradykinin levels, and bradykinin is a vasodilator. Cough is the most common side effect of ACE inhibitors. Angioedema, even though rare when it happens, it is a very serious complication. A reversible increase in creatinine up to 30% is seen in many patients. Hyperkalemia may occur at higher doses, and ACE inhibitors are highly beneficial in cardiac failure and chronic kidney diseases. ACE inhibitors are not to be combined with ARBs and also not to be used in pregnancy. Best when combined with diuretics, and it has to be combined with utmost caution because sometimes it may cause severe hypotension. Angiotensin receptor blockers or ARBs act by blocking angiotensin 2 receptors. They are similar to ACE inhibitors in all respects except that they do not cause cough or they very rarely do cause angioedema. ARVs are preferred over ACE inhibitors if they are available and also if they are affordable. Thiazides and thiazide-like diuretics, they work by increasing the excretion of sodium. Benefits include reduction of stroke and major cardiovascular events. Chlorthalidone is more effective on blood pressure and it is also having a longer duration of action than hydrochlorothiazide. Main side effects of diuretics include hypokalemia, hyperglycemia and hyperuricemia. They are best combined with ACE inhibitors or ARVs. Thiazide diuretics better not be combined with beta blockers because both of them produce hyperglycemia and may precipitate diabetes mellitus. Calcium channel blockers, as the name suggests, they act upon the calcium channels in arterial smooth muscles, and there are mainly 2 categories, dihydropyridines and non-dihydropyridines. Main side effect of calcium channel blockers is peripheral edema, which is again more commonly seen in higher doses, and they are best combined with ACE inhibitors and ARBs. Non-dihydropyrimidines reduce heart rate and contractility. For this reason, it is not recommended in patients with heart failure. Again, dihydropyridines can be safely combined with beta blockers, but not non-dihydropyridines. Beta blockers act by reducing the cardiac output and also the release of renin. They have proven benefits in patients with myocardial infarction and heart failure, and they are the drugs of choice in patients with history of MI and heart failure. They causes hyperglycemia and it is not recommended in patients who are also having diabetes mellitus. and they should not be combined with diuretics for the same reason that both diuretics as well as beta blockers, they increase the blood glucose levels. Side effects of beta blockers include sexual dysfunction, fatigue, and exercise intolerance. Labetalol is a beta blocker that is used very commonly in pregnancy and also in hypertensive emergencies. Alpha blockers, they act by blocking the arterial alpha adrenergic receptors, and they are useful mainly in the treatment of resistant hypertension in combination with agents such as diuretics, beta blockers, and angiotensin converting enzyme inhibitors. They can also be combined with diuretics. They are also useful in patients with benign prostatic hypertrophy who are also having hypertension. Centrally acting agents reduce sympathetic outflow from the CNS, and their side effects include drowsiness and dry mouth. Alpha-methyl dopa is one centrally acting agent which is widely employed for the treatment of hypertension in pregnancy. Direct vasodilators often cause fluid retention and tachycardia. They are most effective when they are combined with diuretics and beta blockers, and they are used only as a fourth line or later additions in the treatment of hypertension. Minoxidil is a direct vasodilator which causes unwanted hair growth, and for that reason it is also used for the treatment of baldness in certain instances. Mineralocorticoid receptor antagonists, the best known agent is spironolactone, and this also can be used as a fourth line drug in resistant hypertension. Major side effects include gynecomastia and sexual dysfunction, and hyperkalemia is also common because spironolactone is also a potassium sparing diuretic. Coming to resistant hypertension, resistant hypertension is defined as blood pressure not controlled with 3 drugs in full dose. Usually, 2 drug combinations control BP in approximately 80% of patients. Home blood pressure monitoring is required to confirm that the hypertension is in fact resistant to treatment. Addition of fourth line drugs like a mineralocorticoid antagonist such as spironolactone, a beta blocker, a centrally acting agent, an alpha blocker, or a direct vasodilator will often be helpful. Very commonly, non-compliance to drugs is one of the commonest reasons presenting as resistant hypertension. We need to ensure that the patient is consuming the prescribed drugs. Also, another very common cause of resistant hypertension is the use of non-steroidal anti-inflammatory drugs and other drugs which increases the blood pressure. These include cold remedies and some antidepressants, and also unrestricted intake of salt. And finally, resistant hypertension is very common in secondary hypertension. Secondary hypertension can be diagnosed usually when there is sudden onset of hypertension, loss of BP control in patients who are already having controlled essential hypertension, and also occurrence of hypertensive emergencies. The commonest cause of secondary hypertension is chronic kidney disease. Other causes include aldosterone excess, sleep apnea, renal artery stenosis, and coarctation of aorta. This algorithm summarizes the management of hypertension using the common categories of drugs. If the blood pressure is above 140 upon 90 millimeters of mercury, start with lifestyle changes. If the hypertension is stage 1, that is BP up to 159 upon 99 millimeters of mercury with other risk factors or complication, start with single drug. If the age is less than 60 years, the drug of choice for monotherapy is either a ACE inhibitor or an ARB. If needed, go on to add a calcium channel blocker or a thiazide. If still uncontrolled, use a combination of calcium channel blockers, thiazide diuretic, and ACE inhibitor or an ARB. In stage 1 hypertension, if the age is above 60 years, start with a calcium channel blocker or a thiazide. Go on to add an ACE inhibitor or an ARB if needed. And finally, if further needed, again the combination is the same: a calcium channel blocker plus a thiazide plus an AC inhibitor or an ARB. In stage 2 hypertension, where the patient is having a blood pressure equal to or above 160 upon 100 millimeters of mercury, all patients need to receive treatment at the beginning itself, and usually the treatment is started with two drugs. The drug combinations are: the first drug can be a calcium channel blocker or a thiazide diuretic, and the second drug can be an AC inhibitor or an ARV. If needed, add a third drug, and again in the three drug combination it will be a calcium channel blocker plus a thiazide plus an AC inhibitor or an ARV. So in essence, whether it is stage 1 hypertension or stage 2 hypertension, or whether the patient is above 60 years or below 60 years, if three drug combination therapy is needed, you eventually end up giving a combination of calcium channel blockers plus thiazide plus ACE inhibitor or ARV. In resistant hypertension not responding to three drug combination therapy, you can add spironolactone or a beta blocker or a centrally acting agent or an alpha blocker or a direct vasodilator as needed. To conclude, hypertension is a very common chronic condition that can easily be diagnosed and managed in the community just by following these simple guidelines. I strongly recommend that you download a document that I've uploaded onto my website, which contains the doses of drugs belonging to each and every category that we have described here. You can either scan the QR code or follow the link that is given here. And I wish you all success in the treatment of hypertension in the community. Thank you very much.